So today in this lecture, we are going to see if a patient presents with diarrhea, how do we go for evaluation of this patient. Now, see what is diarrhea. Diarrhea is 3 or more loose stool per 24 hours. So if a patient passes 3 or more loose stools in a day's time, this is called diarrhea. Now, if we translate into weight, if it is more than 200 grams of stool weight per 24 hours, this is diarrhea. But usually we measure it in the frequency of stools per day because generally it's cumbersome to measure the weight of the stool for every patient. So it is 3 or more loose stools per day. This is called diarrhea. Now this diarrhea can be acute. If the symptoms they settle down within a period of 14 days, this is called acute diarrhea. So acute diarrhea does not persist beyond 2 weeks time, while if it persists beyond 2 weeks time, this is called chronic diarrhea. So if the symptoms they persist for more than 14 days or 2 weeks, this is called chronic diarrhea, and sometimes this is also called persistent diarrhea. Now the acute diarrhea, it can be caused by infections, it can be caused by certain preformed toxins. So the infections, a lot of viruses they cause diarrhea, for example rotavirus, and we see in next slides what are the other causes of viruses which can cause diarrhea. It can be caused by bacteria, for example Shigella, E. coli. It can be caused by even Salmonella or Bacillus cereus. E. coli is an important cause of traveler's diarrhea. And then certain toxins, for example preformed toxin of Staphylococcus or the toxins of the enterotoxigenic E. coli, they can cause diarrhea. Now the diarrhea can be watery. The watery diarrhea is usually because of the toxins or the non-invasive infections. Viruses cause watery diarrhea. Vibrio cholera can cause a watery diarrhea. Then you can have bloody diarrhea, which can be caused by certain bacteria, for example Shigella or enteroinvasive E. coli, or it can be caused by infections like amoebiasis, the entamoeba histolytica, that it can cause bloody diarrhea. Then the diarrhea may be malabsorption type, for example in giardiasis. Giardia lamblia infection affects the proximal small intestine and produces a diarrhea which is malabsorption type. It may be accompanied by pain, or diarrhea may be without pain. Chronic diarrhea. Chronic diarrhea, again, it can be because of the infections and it can be non-infectious. The infectious causes of diarrhea, the most important is tuberculosis. You see, if you take of chronic diarrheas which are infectious, tuberculosis, particularly in the developing countries and those patients who are suffering from HIV, tuberculosis is an important cause of chronic diarrhea. Then amoebiasis, Yersinia, giardiasis, small intestinal bacterial overgrowth, and then you got, in very rare circumstances, fungal colitis. So these are different causes of infectious agents which can cause chronic diarrhea. And then there are non-infectious conditions which can produce chronic diarrhea. These include inflammatory conditions like inflammatory bowel disease, that is ulcerative colitis or Crohn's disease. Then you can have osmotic diarrhea because, for example, lactose intolerance, malabsorptive diarrhea in multiple diseases, and then you've got dysmotility diarrhea, in which the motility is enhanced, usually seen in functional bowel disorders like irritable bowel syndrome. Now the chronic diarrhea. When we evaluate the chronic diarrhea, basically we ask the diarrhea is bloody or it's not bloody. In a younger patient, a diarrhea which is bloody is usually ulcerative colitis, while in older patients after the 60s, the diarrhea which is bloody is usually ischemic in nature. So in younger patients, it's ulcerative colitis. In older patients, it is ischemic colitis. And then there are other causes of bloody diarrhea. For example, radiation proctocolitis can result in diarrhea. Tuberculosis and amoebic colitis, if it becomes chronic, it can result in bloody diarrhea. Then you got watery diarrhea. Watery diarrhea is because of the ileal diseases. The distal ileum, if it is involved, it produces watery diarrhea. Ileal diseases like tuberculosis, Crohn's disease, lymphoma, Yersinia, pseudotuberculosis, they produce disease in the terminal ileum, they produce watery diarrhea. So the watery diarrhea can be a result of involvement of the distal segment of the small gut, which may be caused by organism like tuberculosis, or it may be Crohn's disease, or it may be lymphoma of the small gut, it may be Yersinia pseudotuberculosis. And if we exclude that, then we got uncommon causes. For example, if the ileum is normal, it may be caused by villus adenoma, which is present in large intestine, and then rarer tumors can produce watery diarrhea like VIPomas, the carcinoid or the ZD syndrome, which are actually endocrine secreting tumors, and they cause a large amount of secretion of fluid in the small gut, so they produce watery diarrhea. And then you've got malabsorptive diarrhea. Malabsorptive diarrhea is caused by multiple type of defects. If this malabsorptive diarrhea is without pain and without jaundice, that is, the patient does not have pain or does not have jaundice, this is most likely a celiac disease. It may be tropical sprue, it may be giardiasis, it may be small intestinal bacterial overgrowth, this may be autoimmune enteritis, this may be Whipple disease, and some of the ileal diseases, they can also produce malabsorptive diarrhea. For example, we saw in lymphoma and tuberculosis. But classically, if this is without pain and it is without jaundice, these are the diseases like celiac disease, tropical sprue, giardiasis, small intestinal bacterial overgrowth, Whipple's disease, autoimmune enteritis. They can cause diarrhea. But if the malabsorptive diarrhea is with jaundice and there is plus minus biliary pain, this is obstructive jaundice. So the diarrhea which is accompanied by jaundice and may have abdominal pain or may not have abdominal pain, this is caused by obstructive jaundice. Then if you've got diarrhea which is present with upper abdominal pain and it is without jaundice, this is a consequence of pancreatic insufficiency, that is chronic pancreatitis. So chronic pancreatitis causes pain but there is no jaundice with diarrhea. If there is pain and there is jaundice with diarrhea, this is biliary obstruction. The biliary obstruction which is of large guts generally produces pain, while the biliary obstruction which is seen in small gut, for example in primary biliary cirrhosis, that does not produce pain. So if the diarrhea, malabsorptive type of diarrhea means there is large amount of fecal fat in the stool. So the patient may have this without pain and without jaundice. This is the proximal small gut, which means celiac disease, tropical sprue, giardiasis, small intestinal bacterial overgrowth, Whipple's disease, and autoimmune enteritis. In fact, some of the drugs can produce a similar condition as celiac disease, which is similar to celiac disease. It's not exactly like celiac disease. For example, the angiotensin receptor blockers can produce a similar condition. And if a patient has malabsorptive diarrhea with jaundice, with or without pain, this may be biliary obstruction. And if the diarrhea is without jaundice but there is abdominal pain, the patient is suffering from pancreatic insufficiency because of chronic pancreatitis. Osmotic diarrhea means patient has large number of osmotic particles in the stool. So this is a diarrhea which is characterized by high osmolarity of the stool. So stool, when you examine the osmolarity, it is high, and this diarrhea improves with fasting. And some of the diarrhea of malabsorptive type, it also improves with fasting. Classical example of osmotic diarrhea is lactose intolerance. When the patient cannot digest lactose, this is fermented by the bacteria and produces large number of osmotic particles. The osmotic particles, they draw water and increase the volume of the stool, that results in diarrhea. And then osmotic laxative, they are another example of osmotic type of diarrhea. And then diarrhea can be part of the systemic disorders. For example, neuropathy, autonomic neuropathy. The most important reason for autonomic neuropathy is diabetes mellitus. Then there are other causes of autonomic neuropathy which can cause diarrhea. Patient can have diarrhea in thyroid disease. Patients who have hyperthyroidism, they usually have hyperdefecation. That is, the stool frequency is increased, but they also can have diarrhea as well. And then diarrhea can be part of the functional syndromes like functional diarrhea, or as part of the irritable bowel syndrome, patient can have diarrhea. And then certain drugs, they can cause diarrhea. So you see, these are multiple reasons of chronic diarrhea. Now, how we differentiate this is a small bowel diarrhea or this is a large bowel diarrhea? So it's important to differentiate between small bowel diarrhea and large bowel diarrhea. So small gut diarrhea and large gut diarrhea, because it makes it easier for the physician to go for the further diagnostic proceedings. Small bowel diarrhea is characterized by frequent large volume watery diarrhea. Since the surface area of the small intestine is large, they tend to have large volume watery diarrhea. It's frequent. When in large bowel, the diarrhea is very frequent, but the volume is small. This may be mucoid or this may be bloody, and patient may have tenesmus. Tenesmus means that there is feeling of incomplete evacuation of the bowel. That means there is involvement of the distal portion of the spot, that is rectum. So in small bowel diarrhea, the patient passes large volume frequent watery stools, while in large bowel diarrhea the frequency is even more, but the volume is small. The diarrhea may be mucoid. It may or may not contain blood. There may be tenesmus. Blood may be positive in small bowel diarrhea, but it's not grossly seen. We can see it in microscopic testing that the patient has blood. Very rarely patient has large amount of blood in small gut diarrhea, but in large gut diarrhea, patient can have grossly bloody stools. So if there is large amount of blood in the stool, this is most likely coming from the large bowel. pH usually is less than 5.5, and there may be reducing substances present in the small gut diarrhea. So the small gut diarrheas are a little more acidic, and they may contain reducing substances. Reducing substances sometimes may not be present, but if they are present, they are usually a feature of small gut diarrhea. While the pH in large gut diarrhea is usually more than 5.5, and there are no reducing substances in large gut diarrhea. So if we test the stool for reducing substances, if they are present, this is small gut diarrhea. If they are absent, this could be large gut diarrhea or this could be small gut diarrhea. Large gut diarrheas have higher pH, small gut diarrheas have lower pH. Then in small gut diarrhea, WBCs are less than 5 per high power field, and there is usually no peripheral leukocytosis. The peripheral leukocytosis in the blood is usually normal. While in large gut diarrheas, the WBCs are usually greater than 10 per high power field, and there is possible peripheral leukocytosis. So blood may contain more leukocytes, and there may be band forms, that is immature forms of the WBCs may be present. And these are different organisms which can involve small gut. For example, rotaviruses, adenoviruses, calciviruses, the noroviruses or astroviruses. These are different viruses which can involve patients with small gut. Then enterotoxigenic E. coli, Klebsiella, Clostridium perfringens, cholera and Vibrio, they can all cause diarrhea in small gut type of infections. Then Giardia and Cryptosporidium species can produce diarrhea. While in large gut, it is E. coli, it is enteroinvasive and enterohemorrhagic. Shigella, Salmonella, Campylobacter, Yersinia, Aeromonas and Pleomonas, they can affect. Then Clostridium difficile, this can infect the large gut, and Entamoeba histolytica. So these are different organisms which can affect the small bowel or they can affect the large gut. Now clinical evaluation. Look for the stool characteristic. What is the consistency, what is the color, what's the volume, and what's the frequency. And sometimes you can also think of what is the smell in the stool. Presence of associated enteric symptoms. For example, patient has nausea, vomiting, abdominal pain, or if the patient has fever. So that tells us about there may be invasive infection if the patient has fever as well. So look for the stool characteristics, the presence of enteric symptoms. Then look for the risk exposures. What type of risk the patient is exposed to, but because that can tell us about the type of organism which may be involved. For example, in child daycares, the children have rotaviruses, astroviruses, calciviruses infection. They can have Campylobacter, Shigella, Giardia, and Cryptosporidium infections. So you see, the children who are exposed to daycare, they have this sort of viral infections like rotavirus, astrovirus, and calciviruses. Campylobacter, Shigella, and Giardia may be affecting this. Food ingestion history. For example, if raw contaminated food is taken, there may be food poisoning. Then camping history, possible exposure to contaminated water source, water exposure, swimming pools, marine environment. So look for this presence of exposure to these things. Then predisposing condition, for example, patient is hospitalized, there is antibiotic use, or the patient is immunocompromised, because these conditions can predispose patient to certain type of diarrheas. And then travel history. Pathogen usually affect specific areas, but you keep in mind rotavirus, Shigella, Salmonella, and Campylobacter, they are universally present. They can affect any type of travel. So these organisms are present worldwide. For if you have the patient presents after animal exposure, for example, animal exposures like young dogs, cats, Campylobacter may be involved. In turtles exposure, patient may be affected with Salmonella species. So look for the animal exposure, look for the travel history, look for the circumstances which can cause these gut infections or gut problems. Then when you examine the patient, look for the dehydration. Patient may be lethargic, may be depressed, maybe patient is usually conscious. Look for these signs. Dehydration. Look for the signs of dehydration. The patient is lethargic, depressed but conscious. There are sunken anterior fontanelle, the eyes are sunken, the dry mucous membrane. There is lack of tears, there is poor skin turgor and delayed capillary refill. So you look for the presence of signs of dehydration. The patient will be having tachycardia, the skin and mucous membranes are dry, the fontanelle and eyes are sunken inside, skin turgor is lost, the normal mucous membrane like tongue and the conjunctiva, they dry up, and axillary sweating also decreases. The child shows failure to thrive when there is malnutrition. On examination, there may be reduced muscle or fat mass, or there may be peripheral edema if the patient has pure protein type of deficiency. So hypoalbuminemia causes peripheral edema, especially in chronic diarrheas. Then look for abdominal pain and cramping. Patient may have borborygmi, that is loud abdominal sounds, and patient may have perianal erythema if there have been infections in the lower gut. So look for the presence of these features. Then go for general systemic examination. For example, patient has tachycardia or hypotension, if there is fever, if there is jaundice. So lymph nodes. So look for the presence of all these peripheral signs which may help to determine what is the possible cause of this diarrhea. So this is how we proceed in a patient who presents to us with symptoms of diarrhea. So first we see diarrhea is more than 3 stools per day. It can be acute. If it settles within 14 days, it is chronic or persistent if it goes beyond 14 days. And see, the diarrheas can be infectious and non-infectious. So look for the infectious cause and try to find out or fix the infectious cause, and look for the non-infectious causes as well, and then go for clinical evaluation of the patient. Take a proper history and do a physical examination. In most of the cases, this tells us what is the possible cause of this diarrhea. Some of these patients may require investigations, and the investigation includes the general investigation like complete blood count, the serum electrolytes, the renal function testing, the ESR for the inflammatory causes, and then we go for the specific tests for different type of diseases as is determined by our initial screening of clinical history and examination. So this is how we proceed in a patient who presents to us with diarrhea.